Hello, everyone. Thank you so much for joining us. Of course, October is Breast Cancer Awareness Month. So today we're going to be talking about breast health and the importance of mammograms. And we're going to be we're delighted to be joined by Dr. Charity Dugan. She is with LifeBridge Health, and she has joined LifeBridge in order to take over the practice of Dr. Michael Schultz, who practiced in the Baltimore area for half a century, which is pretty extraordinary as a breast surgeon. So thank you so much for joining us, Dr. Dugan. We do appreciate it.
Thank you.
So once again, it is Breast Cancer Awareness Month. I know LifeBridge has this great program called the Mammathon, which is a good name, and it's from October 21st through November 15th, which is a great way for women who are reluctant or maybe don't have it on their calendar to get their mammogram. And, nothing is more important for women, I think, than taking care of their breast health. So first, let's just start by introducing yourself, if you don't mind. Can you tell us a little bit about your background and your experience in breast health?
Yes, so I trained in New York City for general surgery. I'm a board certified general surgeon and sort of, I think, fell into the niche of breast surgery, so to speak, probably because I'm a female, that doesn't happen for everybody, but I like to be able to follow my patients where you don't always do that after removing an appendix or a gallbladder. And breast patients, specifically breast cancer survivors, you follow with them for the rest of their lives, So I trained in New York City. I'm married to an active duty soldier, so that has moved me around. I have a private practice in Alabama, and they did sort of bring me down there because I spent some time doing rotations and my cancer focused rotations since I was in New York. That afforded me a great opportunity to rotate at Memorial Sloan Kettering, which is like the epicenter of cancer treatment. So I was able to do my breast rotation there, and I did additional time on the breast service as a student in Washington Hospital Center in DC. So that sort of, I think, sparked the niche. And then I went to my first job. That was sort of my main focus, was getting the breast patients, following them. And then our next move was to North Carolina, Fort Bragg. And I worked for the military for 4 years there from 2016 to 2020. At their Army hospital as a civilian, and they had accredited breast center. So I did general surgery trauma call in the breast center. Not all the general surgeons did that. And I think that is really where I learned what a breast center really entails, and all the pieces that are needed. And we were accredited and going through reaccreditation at the time. And so then I was fortunate to have an opportunity where a University of Maryland site in Charles County wanted to open a breast center. So there I found oh, this is what I want to do. And I spent the last 4 years there developing a practice in a county where there's no other breast surgeon. And then Dr. Schultz decided he was going to retire, and somehow I'm here. So it's an awesome opportunity because all those pieces that you're trying to put together are already here, and I'm walking into a thriving practice where I can care for all of those that he did and bring more. So it's a really exciting opportunity.
Talk to me when you're dealing with a patient, how you deal with patient education regarding breast health.
I think I feel like I bring something to the table every time we meet. A lot of patients don't know the basics, and the basics to me is make sure you're checking yourself. A self-exam is really important. Mammograms happen once a year. You're with you 24/7, 12 months of a year. So some people are like, I get my mammograms. Somebody said today, I get my mammograms, right? And I said, yeah, but what happens the other 11 months? You need to check yourself because about 40% of cancers are found on self-exam. 80% of lumps found are not cancer, but 40% of breast cancers are found on self-exam. So it's how the information is translated, right? They're going to go on and get a mammogram and a diagnostic and a biopsy to get the final diagnosis. But that's important to note because I don't think people realize, and a lot of people just don't check because they say they're too lumpy or, there's a lot of reasons. But I make sure in every appointment to emphasize that self-exam and talk about how to perform it, what the borders of the breast are, where you should be feeling. Always remember to check the underarms because breast cancer spreads through the lymph nodes. So maybe you don't feel anything in the breast, but you feel something under here. That's important to also call your doctor and get evaluated.
40%, that's quite a number. I didn't realize that
Yeah.
that high of a number is caught by breast exam. Really quickly, because you're not in an exam room right here, but very quickly, what do you tell women about self-breast exam? Every week, every month, every day?
Monthly is
Monthly.
what's recommended because of our hormone shifts. So it's easy to say once a month, pre or postmenopausally. But if someone's premenopausal and they're still menstruating, it's the best time is within the week after menses, because your hormones are sort of regressing and the whole cycle's starting over. So that's when you're least lumpy, because most of the excuses are, I'm too lumpy, I don't know what I'm feeling. So I said, it's fine. You're not a breast surgeon. We're not expecting you to find the things that mammograms are made to find, and maybe my fingers would find that yours wouldn't. It's really just checking for something on one side that's not on the other. And then sometimes I'll tell them, fine, if you're lumpy, then you're feeling for rocks. Like you want to, it's something that's on this side that's not on that side. Patients that are very cystic, because that's a natural phenomenon of female breast tissue. I will even say, I get it. Like, you don't want to run to the doctor every time you feel one little thing. So there's always this like anxiety about waiting, but we're built on this monthly cycle, even postmenopausally, you pick once a month. So if you feel something here today, we look at the breast like a clock, 12, 3, 6, 9. I'll say, maybe you feel a grape at 11 o'clock today on the left. Write it down, wait till next month and feel. It's probably not going to be there. Next month, it's going to be 7 o'clock, maybe in the left or the right. That's not the same thing. And then you can calm down, because cancer doesn't go away like that. A persistent lump would stay and push us further to evaluate.
So you feel something, it's still there the next month. Is that when you call and say, I think I need a mammogram?
Yeah, I mean, specifically, I'll tell patients that are very cystic that, because they're always feeling lumps and they stress about it. So it's sort of a like, well, let's be reasonable about it and let's give it time to come and go, because cysts are fluid-filled sacs. So with hormone shifts, the body's made to become pregnant. Your ovaries make cysts, your breasts make cysts. They fill with fluid, then they regress. Now, that doesn't mean everyone will fill and go away, but it is the natural cycle of things. There are times that patients come with a painful cyst and we end up going to surgery to remove it because they just can't tolerate it. Those are sort of the outliers. But in general, the hormone flow is the breasts swell, that you're uncomfortable, you're having your PMS symptoms, and then it regresses. And when it regresses, you're less lumpy, the cysts are less full, and you'll feel less. So that's also makes it easier to pick out something that's more prominent, that might not be at the wrong time of the month, we'll say, just to check.
All right, very good to know. So there are risk factors. I mean, we know that just being a woman
Right.
is a risk factor. Is it 1 in 8 women? I don't know what the number is anymore. Yeah, 1 in 8. So what are the other risk factors?
So, there's simple things I think a lot of people just kind of out of sight, out of mind. Smoking's a risk factor for all cancers. I have had many patients come to me and be like, but I'm healthy and I don't have this in my family and they don't do anything wrong. And, I don't smoke, but I understand that it's a habitual thing and it's an addiction. It's hard to kick. But I will say, how long have you been smoking? Like, that's not helping the plumbing kind of thing. So we talk about that. That's a basic risk factor. Also obesity. There's research that says multiple times a week, exercise, getting your heart rate up does decrease the risk of all cancers across the board. So those are things everybody can do. And I struggle with it too. Fitting it in your schedule and getting that heart rate up and staying there for 30 minutes is hard. But those are for everybody, average risk individuals. Then the things that put you more at risk are having your children later in life. So after 35, you're considered, advanced maternal age. A geriatric pregnancy, some of us laugh about. All of mine were geriatric, so
Mine too.
that's life. But that's a risk factor. But then if you breastfeed those children, that helps decrease your risk. Never being pregnant, that's a risk factor. Of course, family history is important to talk about. And there are, last time I checked, 13 genes, not just BRCA1 and 2, but 13 genes across the board that we know that are identified to be associated with an increased risk for breast cancer by the NCCN, accepted by the NCCN guidelines to help us, get patients in for advanced screening, high-risk screenings and things like that. BRCA1, BRCA1 and 2 are the ones that most people know about, but there are others that are associated more commonly with different types and subtypes of breast cancer. So, of course, if you have a genetic mutation, then your risk is way up here. And there's things that we do, advanced screening protocols and whatnot through breast centers to help diagnose and treat early. Also, there's talk of prevention and what that means for each individual patient. But even if you don't have a genetic mutation, but you have people in your family, it's still important to not ignore one side or the other. So I do a lot of counseling in my previous position. I did a lot of high risk counseling and, well, not formal counseling, but screening and counseling, talking about all these things that we know what we know, but we're always learning more. So I'm sure that there are other genes and mutations that we don't know about that will come along in my lifetime and further that are also associated. So if you get the test that's approved today and they have like 95 gene panels and it's negative, but you have grandma, 2 aunts, mother, cousin, that's something to pay attention to, because technically by calculation, 1 first-degree relative, which is mom, dad, brothers, sisters, or 2 secondary relatives, which would be on the same side, like mom's mom, mom's sister. Those 2 things separately would equate to high risk profile. So high risk is technically defined as a patient that has a 20% or greater risk for developing breast cancer in their lifetime. The 1 in 8 number you quoted is 12% of the population is affected with breast cancer. 12% of the women is affected with breast cancer. And it happens in men too. It's like 1 in 800, but in Maryland, the first in my career, I've had multiple patients that are male that have had breast cancer with all different, some family histories, some that could have been environmental. We don't know always, but it does happen.
We often overlook the fact that men get breast cancer.
Yeah.
And they do. I have a friend who did. So if you don't have a family history, the kind that you're describing, you wouldn't just get genetic testing just to know that only happens if you have indications that you may have a family history, correct?
Right. I mean, there are tests you can buy. Even now at Target, you can go buy 23andMe and do it yourself. And you can do that, private, on market, whatever. And, you just want to make sure with all of those tests, you get genetic counseling. Somehow you can talk to a licensed provider through purchasing that test. You need to go over the results and what those results mean for you, or bring it to your own doctor. So there are people that do that. But if you want to have it, official, formal through your insurance, then yes, you wouldn't be approved if you didn't meet certain criteria, like the criteria I talked about, the family history. And so there are several cancers kind of in a grouping. The most commonly genetically associated cancers that I always list and ask when I meet patients are pancreatic, prostate, breast, colon, ovarian, and melanoma. So they don't sound like they all have to do with one another, but my patients educate me. And one time my patient handed me a paper. I was sent patients with Lynch syndrome who have elevated risk for colon cancer. They're like polyposis syndromes. And she handed me this paper and it said patients with the PMS2 mutation, which is the Lynch syndrome mutation, can have up to a 26.2% increased risk for breast cancer. So
wow. I don't think people connect that. I think people think it has to be breast cancer, but you're saying if you have a family history of cancer, different kinds of cancers, doesn't matter. Cancer, that's when you need to be aware.
Right.
Very interesting.
Yeah.
Yeah. All right. So you mentioned obesity, you mentioned smoking, you mentioned we need to exercise. Are there other risk factors that we need to be aware of? I mean, obviously we live in a polluted environment. Not much we can do about that.
I mean, everybody's always like, are you seeing more cancer? Yes. Are you seeing it in more young people? Yes. Do you know why? No. What do you think? Environment. That's me, because we still know that only about 5 to 10% of breast cancers are attributable to genetics based on what we know now. Okay. There's still the majority is spontaneous or sporadic cancers that are developing in healthy people. So, it's, and I say it like that because it's subjective, what's healthy, but like people that are making good choices, buying fresh food, so it's all the things to think about, but it'll stress you out. So you just have to live your life, but you make as best choices as you can, the other risk factors I can think of are a history of radiation exposure. So therapy or, jobs, that can increase risk for cancer development in general. Also a history of hormone therapy, of course, because like we talk about the shifts in hormones, well, most breast cancers also are hormone driven. So when we talk about hormones, we're talking female hormones, estrogen, progesterone. So when we get, cancer biopsies back, a couple of the tests that are always tested or checked are the presence of estrogen or progesterone. And so if you have had additional exposure to that in your lifetime, whether it was for, hot flashes or birth control, all of those things can contribute, fertility treatment can contribute to future development of breast cancer to different varying degrees. People are like, birth control. I'm like, well, I mean, yeah, it's not, I don't think it's a big deal because a lot of us do it, but it's there and it's not off the market, but it's something to think about. So if you have a family history, I mean, you want to be more judicious with the choices you're making,
That's good to know. All right, so you get the diagnosis none of us ever want to get.
Mhm.
We keep advancing medicine, I know, and I imagine that's also the case in terms of breast cancer treatment. What are the options, treatments available for you?
So breast cancer, like many cancers, it's treated multimodality of therapy. So surgery is always important unless you're at the point where surgery is not an option. So surgery is always part of the equation. Radiation is an option, not always part of the equation, depending on the surgery, and then chemotherapy the same. And then speaking back to the endocrine or the hormone side of things, now we also have endocrine therapy that's actually targeting those estrogen positive cancers and helping block that so that we don't propagate a future recurrence of the disease.
Is that
So
what we know of as estrogen repressing
yeah,
therapy? Yeah.
yeah, like so the common ones are tamoxifen for
Mhm.
younger or premenopausal patients
Mhm.
and things like Arimidex or Femara, letrozole postmenopausally. Yeah,
Mhm.
basically driving the estrogen down to take away that fuel to help cancer come back. We don't want it to come back.
And the medical world is getting better at saving lives of women who have breast cancer. Is that right?
For sure, for sure. I mean, we have breast is a huge sample size, so we have so many patients to study and give us information of what we can do when and how that matters to achieve a more positive prognosis. Um, some patients we know it's an aggressive form and we need to do chemotherapy first, and everybody doesn't like that because they feel it's in their body and they want to get it out, but that's not always the right sequence. So the whole modality approach too includes the breast surgeon, the medical oncologist, the radiation oncologist. We all come together and discuss the case and decide what's the sequence. And it's like with anything, you got a plan and it may change, but you start with the standard and move forward.
All right, so we're talking about the mammothon. Who
Mhm.
should get a mammogram? At one time, it was women over 50 and over. Has that changed?
That has changed. So I was looking for the date. I believe it was 2023 that or maybe it was this year. Sorry, I have my papers in front of me. I have that flipped to the wrong page. It's the U.S. Preventative Task Force just changed this. Oh, it was this year, April 30th, 2024. So this is basically Medicare guidelines used to say 50 every 2 years. They still say every 2 years. We don't agree. We say every year. But they got it right down to 40. So for average risk patients, mammogram starting at 40 annually is what a breast specialist or a breast surgeon is going to recommend. I think the GYNs will recommend it. I think most doctors would recommend it, but they might not order it because it might not get covered, because patients are going to get a screening mammogram for free every 2 years if they're a Medicare patient, unfortunately. But the recommendation would be 40 years old every year for an average risk patient, which is patients without all those other things we talked about, family history that's high risk or genetic mutation.
Wow, that's aggressive, and that's good, because I guess that means you'll catch things that if you'd waited till 50, you would not catch, unless you find it in the self-breast exam. All right, so there may be a 40-year-old woman out there who's never had one yet. Can you describe the process? What's it like getting a mammogram?
So it's really fun. No, I'm just kidding.
No, that I won't let you get away with.
It's fun. No, I think from personal experience, it's better than going to the GYN. Sorry, but and you just have to take your top half off or whatever. But the screening mammogram is not as aggressive as if you have to come back for a problem. So it's, you have to take your top off, you wear a gown, you have to, they'll tell you no deodorants, perfumes, or lotions, because your breast is going to be compressed between two plastic plates so that they can take the best views they can, and you don't need to come back unless you really do need to come back. So mammogram is X-ray. So in order to get a picture of your breast, it has to be distracted from your chest, but it has to stay attached. So I always joke, you have to hug the machine, whatever way they tell you to do it, just to go with it. The sooner you cooperate and get it done, you're done. But it's two views is the main goal. A view top to bottom, which is craniocaudal, it's called. You'll see CC if you look at your pictures, and then a view from the outside to the inside, or the inside to the outside, which is MLO or ML, medial lateral, oblique, medial lateral. So it's shooting the x-rays through the breast to catch things at different views. Then also now, I'm sure there are some places that don't do 3D or tomosynthesis, but 3D mammography is the mainstream now. Most places are offering, and that gives us really cool pictures. So if you've had one and they have it like this, and then the machine, they tell you to hold your breath, the machine goes, it's taking pictures, and we can actually scroll through that on the computer and see three-dimensional images. It's neat. It's like a movie. Neat to us, but good for you, because we can see, is it just a shadow on one static view, or is it a three-dimensional something that we need to be concerned about? So that's the process. You go, you get the pictures. It doesn't take long. And then depending on where you go, most places now, I believe, are giving you a letter saying you're good or not. It depends if the breast radiologist is physically in and reading that day. A lot of times breast radiologists aren't at the same location, and there might not be one at your location that day. So then they're going to send you a letter. I think that the guidelines or the recommendations, or whatever you want to call it, the rules, are 30 days they have to collect any mammograms from other places, if you're not going to the same place every time, to send you the letter. So I do always tell patients, well, did you get a letter? And sometimes so your ordering doctor should receive a result, and that should be uploaded on whatever electronic medical record that physician has available to you. So those are the different ways that you have accessible to know the results.
The waiting is sometimes much harder than the actual process of mammogram.
Right.
So you talked about, what about, I know when I go to get a mammogram, they give me options, and I have to pay out of my own pocket for the options, but they include ultrasounds, they include, different kinds of things. And I know you described one of them, which is the is that what you're talking about when you say sonogram?
Something I noticed that's come around, I think it's this year mostly in our area, is artificial intelligence. AI is coming into everything. So I've noticed patients with different reports, and they say, Dr. Dugan, they asked me if I want to pay, $40 extra for this. What do you think? And I said, well, it's like two people reading it, because the doctor's going to still read it, and I say the robot is reading it too, which is the programming. So I don't know. I don't feel like we're there yet, that the AI is increasing our numbers, so to speak, because we haven't been using it that long, and time will tell for that. So that's one of the options. As far as ultrasound and MRI is another thing. I always tell patients there's 3 ways to look at the breast. There's mammogram, which is X-ray, ultrasound, which is sound waves, and MRI. And most people have had an MRI for a joint or something where you lay in the thing and it's a long time, you know. Breast is a different kind of experience in that because you lay on your belly. So most people remember that because it's kind of like you lay like Superman for 45 minutes taking a picture, but everybody doesn't get an MRI or an ultrasound. There's not enough data out there to say that everyone needs those. So the gold standard for screening for breast is a mammogram. We use ultrasound as an additional test to evaluate for diagnostics for problems. So if a patient comes with a lump, then we go to a diagnostic mammogram over a screening and add an ultrasound. If a patient goes for their screening mammogram and has an abnormality, then we send them back for a diagnostic mammogram with an ultrasound. That's where we start. Then the other questions come into play about the genetics and the family history. And another thing that's mentioned a lot lately, several years or so, is breast density. So you'll read that in a line on your report, usually heterogeneous density. How do they say it? They say like extensive or extreme breast density. Breast density means an X-ray isn't going to pick up everything. So if I have a patient that has a concern and their mammogram's clear, then you kind of have to go through the list because then, get the insurance to get on board. You get the diagnostic mammogram, the ultrasound. If those don't show anything, but we still have a problem, then I push for an MRI. So, go ahead.
No, it's a lot. I mean, so before we leave everyone, because it is a lot, let's make this very clear though, however, because a lot of women put this off because they're afraid, they think it's uncomfortable, they don't want to know, because of all the things we just talked about, because there could be more tests coming and the whole thing, that it's almost like if I don't think about it, if I avoid it, it just won't be real. So we want to cut through all of that in this month in particular, and reassure women that no matter what, there are so many advances, correct? That learning early, diagnosing early can make a huge difference.
Sure.
Go ahead, you say it. You're the doctor. They won't listen to me.
No, I mean, always the most important thing with finding and knowing, knowledge is power, right? Like if you avoid it, I mean, it's your prerogative, it's your body, but it's not advised. I have had patients say, okay, this is it. You've told me. What happens if I do nothing? And, I'm kind of like, I'm a sensitive person, but I like to smile and laugh. All my patients they'll say, well, what's going to happen if we do nothing. But in all seriousness, like the advanced disease is very painful and not a fun way to go through any of this. So even if it's to the point where we can't do every single little thing and it's not perfect because life isn't that way, there's going to be something that we can do for you. Something, somewhere, one of us, to make it not so hard.
Yeah, and prolong your life or save your life.
Yeah.
All right, so well said, very informative. Numbers that stick out to me is 40% found by women doing self-breast exam. 40 years old is when we want to start this mammogram now, and every year, as opposed to every other year. These are really important numbers for everyone to keep in mind. And another number is this October 21st through November 15th, which is your mammothon. What do women do if they want to participate?
I am not. Thank God this is getting. I'm not very.
Don't worry, we'll put up a slide. We'll let everybody know, and you can obviously just go to LifeBridge and
right. I know
click on Mammothon, and you'll find out.
Yeah, there's a link on the website. But I'm honestly not very. I'm very new here. So
that's right, and we're thrilled to have you. So welcome, welcome, welcome. It's very easy. Go to LifeBridge, click on Mammothon. You'll find out all the details. So many medical institutions in the month of October want to make it easy for you to get a mammogram. This is the month. I have my appointment next week. This is the month, everyone. If you don't have an appointment already, and sometimes they're hard to get in advance, this is the month you're going to find LifeBridge and other institutions trying to make it accessible for you. So take advantage, take advantage. Well, Dr. Charity Dugan, thank you so much for joining us, and we do welcome you to LifeBridge, to Baltimore, to the region, and we're so grateful to have you here with all of your extraordinary knowledge and expertise.
Thank you so much.
All right, thank you, and we'll see you soon.
Thank you. Bye.
Bye.